So we would transition now to our fourth and final panel for the day, which is entitled Opening Doors: How Emerging Programs Are Growing Housing Options for Older Adults. And as background, as our speakers come to the fore, in recent years, the state has taken measures in order to address the growing number of Californians falling into homelessness. Programs such as the community care expansion have allowed for the expansion of permanent supportive housing and assisted living for lower income Californians. The Behavioral Health Services Act, while in the process of implementation, is looking to make housing a funding priority to bridge the gap between behavioral health needs and housing. Our fourth panel will examine these programs and their ability to expand housing capacity for older adults who need supportive services, and what policy changes could unlock their full potential. And with us, we're delighted to have Brenda Grealish, Executive Director of the California Commission for Behavioral Health, and a good friend of the Commission, Casey Mills, Bureau Chief for the Community Care Expansion Bureau with the California Department of Social Services, Housing, and Homelessness Division. Thank you both for joining us.
Oh, you gave me control of my slides. That is dangerous. Actually, I think you might be first, Brenda. You wanna-
I believe Brenda's
was actually
slides are up for. Oh,
I think we're going to do it the opposite because I think you were going to do the kind of the broader housing and then I was going to talk about the service.
Sure, sounds good.
please.
Okay.
Okay.
And I get it back. Yes. Okay, so thank you so much for having me here today. We always appreciate the invitation from you all. My name is Casey Mills. I'm the Bureau Chief for the Community Care Expansion Bureau within the California Department of Social Services. And I'm going to be talking about the Community Care Expansion Program today, a broad overview. First, I kind of want to start by situating CCE within CDSS, within the Department of Social Services. So we're housed within CDSS's Housing and Homelessness Division. We provide 6 different programs, housing programs throughout the state. They're tailored to the needs of adults and older adults with disabilities. We have the Housing and Disability Advocacy Program, Home Safe, and our Community Care Expansion Program. So our programs are really integrated with social services. We feel that by embedding these programs, our assistance within social services, we reach a whole greater, broader swath of people and create direct access to their housing. Go to the next slide. So you've heard a lot about this today, and I don't know that I need to belabor the point, but there's a dramatic gap between what's affordable to older adults, particularly older adults with disabilities, and what the current market rent is in the state. So you see up there in 2025, fair market rent was $1,581. You'll also see that many older adults on SSI, SSP are relying on a fixed income. That fixed income is well below just the fair market rent, and that's not accounting for daily expenses, groceries. I think you know all these things very well, but it's important to underline just how significant the economic gap is for older adults with disabilities. So the Community Care Expansion Program was really developed for the preservation, acquisition, construction, and rehabilitation of housing. It has supportive services alongside that housing, and it's directly servicing older adults who are facing or have experienced homelessness and are on SSI, SSP, or CAPI. We were established in 2021. We originally had a goal of 7,000 statewide beds to be preserved, and we recently surpassed that, which we're really proud of. And I'll be talking a little bit more about how far we surpassed that later, but that is an overview of the program. So within CCE, there's actually 2 really distinct different programs. There's the expansion and the preservation. The expansion had 570 million, and that's really for brick and mortar type buildings. So actual structures, funding the construction or rehab of those structures, creating new units of a diverse array of housing types. So licensed care facilities, permanent supportive housing, recuperative care. You'll see some more examples later on. But that was really grants to developers, nonprofits, and governmental entities to build new housing. The preservation side is a little different. That's really about preserving already existing licensed facility beds. So that money goes directly to counties Counties develop a program for implementing, and then it goes directly to facilities. There's some more nuance to the preservation side, and I'll get into that a bit later, but 247 million has been allocated for preservation. Still getting used to not saying next slide. I'm gonna just the brain connection is gonna happen any moment now. So one thing we really had to do a lot of with CCE is that on the county side, this was often a brand new program. Like, how do we reach out to facilities? How do we connect with facilities? How do we find those in real need of operating subsidies or capital expenses that we can help with? So we provided a lot of technical assistance to counties on that front. On the expansion side, we tried to serve a diverse array of developers. So not only kind of like bigger nonprofit or county type developers, but also some of those smaller mom and pop facilities that wanted to expand or develop a small scale facility. And they don't have a huge staff and a huge technical budget and people that can fill out big grant applications. So we really tried to provide technical assistance to them to make that process easier and give them access to some of our funding. So this is a broad overview of both programs. We have 39 counties that are participating in some way. And so far we've created or have committed to be preserved 8,385 beds or units. So I'm going to dive a little bit deeper on the capital expansion side. Remember, this is more the brick and mortar. The first thing I really want to focus on is those first two upper boxes. We had a request for $3.9 billion in funding. And when we ran that number, we were like, this has got to be wrong, ran it again, ran it again. That's how much money was requested of us. And that's the gap for housing for older adults that we see out there. That's how high the demand is for this type of funding, for this type of housing. Received 374 applications. That took a long time. I'm just going to say that. So we were only able to award 61 projects. That's still 61 projects that would not have existed without that CCE funding. Allocated at almost $570 million and 3,170 beds or units are coming out of that funding. And I'll just point to that list there. It's a real diverse array of housing types. PSH, recuperative care, sober homes. We really wanted to be flexible in that because we wanted whatever was needed most in that community to be built in that community. And we'll talk a little bit more about that later. Also want to point out we had 4 projects developed by tribal entities. Just some more details. The graph on the left shows the different regions we funded throughout the state, kind of every corner of the state. The graph on the right shows the diverse array of housing types. One thing I want to point out there is just sometimes it's mixed, which I thought was really cool. You have a licensed facility and PSH beds on the same site, or you have an ARF with recuperative care on the same site. So kind of blending the housing types on the same type. We're in the really cool part of this project where we get to go out to grand openings and groundbreakings. And I got to hold a little golden shovel, which was a lifelong dream. And I used the big scissors, which was really cool. They're harder to operate than they look, or maybe they look hard to operate, but I failed at it. But just where we are in sort of project milestones, we have 15 projects that are already under construction. We have 5 projects that are completely done, but people haven't started moving in. And then we have 11 projects where people are actually moving in, which is really exciting. Okay, little deeper dive on preservation. So again, CCE is kind of built in with 2 big components, preservation and expansion, and then preservation itself has 2 components. The first are operating subsidy payments, and these are regular payments given to facilities that are experiencing operating deficits. And you may have heard there's a lot of licensed facilities out there, again, mom and pops operating on a very thin line, not making hardly any money, relying on SSP payments to really keep them open. And these funds are really, really important. Counties give those directly to those facilities that need them, and they're able to keep the doors open with those operating subsidy payments. The capital project funds are more for our HVAC broke or our roof is going out. And for these smaller facilities, a big capital expense like that can really ruin them. I mean, it can really close their doors. So this funding is really so they're able to keep open through these capital projects, and the county funds those as well. Preservation overview. So we have 34 participating counties. It was totally voluntary. And we have 7,423 beds that are committed to be preserved. So just a few project highlights just to kind of show how this has been implemented on the ground. In Siskiyou County, they used all of their preservation dollars to preserve one facility. It's an extremely rural county way up north. And they came to Housing California with us and presented with us. It was a really touching story. Basically, there was a facility that served a massive geographic area and it was about to close. And through CCE, they were able to keep their doors open by providing them both capital funds to keep the infrastructure up to date and also to provide those monthly payments to keep their door open. Santa Barbara County is a cool county in that it was able to mix both types of funding. So they would use both preservation dollars to preserve the existing beds, but then they also used expansion dollars to create new beds. One of the projects was a county funded facility, which is really neat. So they were able to really hone in and find out what exactly kind of new beds do we need for our population, and then construct those beds using expansion dollars. San Bernardino, similar county, used both sources of funding. They also created a county created facility. And the exciting thing about that is it's one of those facilities that includes different types of housing right on site. So you can get your medical care on site, you can get your supportive services on site, and you're housed on site. So diverse array of housing on the same site. Couple pictures. This is Alameda Point Collaborative's project that recently opened. Recently attended a grand opening for this one. It's in Alameda County, 140 beds and units, and a real diverse and comprehensive array of supportive services for the residents on site. Mental health services, ways to be social on campus, just a really cool spot. And then this one, I think other people usually do this presentation, so it's weird there's pictures of me on this slide. So just want to apologize for that. But this is Sienna Terraces in Placer County, 78 new beds. Went up to the groundbreaking of this one, which was really cool. They have a real behavioral health focus. One thing I loved about this is it's literally across the street from Sutter Hospital. So just a huge array of medical services right where the housing is. You can walk to multiple doctors just right from where you're living, which I thought was an awesome thing. Those are outcomes to date. Again, just want to highlight that blue box. So far, we've created or preserved 8,385 beds or units. We think that number is going to go up because that's a point in time count, and counties are still implementing their preservation programs. But as always, thank you so much for the opportunity to present. You know how to get a hold of me, and I'll hand it over to Brenda.
Thank you. All right. I don't know if I can back it up to my slide, which is just me. But I'm Brenda Grealish. I'm the executive director for the Commission for Behavioral Health. I'm really excited to be here with all of you today to even open up lines of communication between our commissions to be able to work more closely together on a lot of the work that's happening with Proposition 1 implementation. Proposition 1 is the Behavioral Health Services Act passed in 2024 by voters. I'll start off with maybe a little bit of a history lesson because I've actually been in this system since the late 90s. So I've been around for quite some time. I was here when I was working at the former Department of Mental Health when the original Mental Health Services Act passed in Prop 63. So kind of been a kid growing up in the system throughout my entire state career. And so I've really I had an opportunity to kind of watch the evolution of this over these last couple of decades. And, really in the beginning with the Mental Health Services Act, it grew from a project in LA County, which was the village. It's AB 34, became AB 2034, and that evolved into what became Prop 63. At that time, we did not have uh, Medi-Cal available to some of our individuals who were living with the highest behavioral health needs. And so some of these projects in LA County were showing that when you apply a whatever it takes approach to really helping support all the needs of an individual, then we see more successful outcomes. We see lower incarceration, lower homelessness, and just better health and wellness. And so really MHSA started off and really trying to focus on those with the highest behavioral health needs and kind of evolved over the years and kind of grew into prevention. We didn't have any dedicated prevention resources at that point in time. We had EPSDT for our children and youth population, but there was a lot of it was fairly new because our specialty mental health waiver had only been around since about 1995, and as you can imagine, when you're implementing these very complex programs, it takes a while to really implement and kind of work through these programs and the challenges as you implement them. And so, fast forward, we're in the 2010s, and we had the fortune in California to be able to implement the Affordable Care Act on January 1, 2014, which was just monumental for our single childless adults population that did not have access to Medi-Cal. A lot of those folks were being served by the Mental Health Services Act, and so it really opened up a whole new opportunity to be able to serve this population. We as a state also opted in to provide what we call non-specialty mental health services in our Medi-Cal managed care plans. Some might refer to that as for the more mild to moderate conditions, behavioral health conditions. And so that has been growing. It's also not really well known that those services are available in our Medi-Cal managed care plans. So now we're kind of moving forward and evolving the Mental Health Services Act, and we're kind of back to that kind of original intent, what we saw back in the early 2000s of really focusing in for counties to really focus in on the highest individuals with the highest behavioral health needs. So really that's what counties are tasked, county behavioral health departments are tasked with, is really focusing on individuals who live with serious mental illnesses and or substance use disorders. Another big change with Proposition 1 was to allow funding to be used for substance use disorder only. So with Prop 63, there had to be a nexus to a serious mental illness for those dollars to be used. And now with Proposition 1, somebody can have a substance use disorder alone, a diagnosis alone, and still be able to benefit from Behavioral Health Services Act funding. There's also a lot more accountability with the state. So really, the Department of Healthcare Services has a lot of the Mental Health Services, or sorry, Behavioral Health Services Act implementation responsibilities. And so they've been really leaning in and providing county behavioral health departments with all the guidance necessary. There's a community planning process that's was always around with the Mental Health Services Act. You guys may have heard the mantra of "nothing about us without us." So that really grew in popularity and just really getting that message across with the Mental Health Services Act, and is continuing under Proposition 1 as well. And there's a very important emphasis on the community planning process for the Behavioral Health Services Act. So counties have been working on their 3-year implementation plans, BHSA implementation plans, with that community involvement. So they are right on the eve almost of having the final implementation plans due on June 30th. I will say some of the other changes with Behavioral Health Services Act are the funding allocations. We used to allocate 95% of the revenue generated from the millionaire's tax. 95% would go to the counties, and 5% would stay at the state level for what we called state administrative activities. Now, with the Proposition 1 Behavioral Health Services Act, it's a 90-10 split. So 90% now goes to the counties, 10% stays at the state level. Of the 10%, there's 4% dedicated to population-based prevention activities, which is spearheaded by the California Department of Public Health. We've got 3% going to healthcare access and information for workforce investments. And then the 3% bucket is basically what used to be our 5% bucket. It shrunk to 3%. And that's really the state, the remaining state funding that goes to a variety of different departments. It funds like the Department of Healthcare Services. It funds us as the Commission for Behavioral Health, other departments such as CalVet. There's a variety of different departments who get funding out of that final 3%. And so there's a lot of changes happening. I'd say also for the commission, with Prop 1, we moved from 16 commissioners to 27 commissioners. So we now have 27 commissioners that represent a lot more perspectives of what's needed to really wrap around populations. And so we do actually have a housing representative now. Chris Contreras from Brilliant Corners is our housing representative. Unfortunately, he couldn't be here today, but he's been a wonderful resource to us as we as a commission have begun to start expanding our horizon to really think about housing, because now with that 90% going to the counties, housing now is a much bigger piece of that pie. So and the state has done a lot of work and investments in terms of housing dollars. So we had the behavioral health bridge housing, or BHBH, which was really leading up to what has now become that 30% in that allocation of the 90% that goes to the counties. A lot of counties I know have been really messaging that they didn't get new funding, and that was something that I think was an important nuance for people to be aware of. It wasn't new funding; it's a shift in funding. Behavioral health bridge housing kind of got them started, and now they'll continue on. In terms of the with the older adult population, I mean, there's a variety of different opportunities, I think, to be able to advocate for older adults. And the community planning process is one of those key areas. Really bringing data to the table at those local. It's so locally driven with Behavioral Health Services Act that really having that information, being able to advocate for the unique needs of the older adult population. It's something we're wanting to look at as a commission, just in terms of as we're moving towards this high needs population and really focusing in counties, focusing in on the high needs behavioral health population. We have actually updated our strategic plan, putting our strategic plan through the lens of the Behavioral Health Services Act. We've got 4 priorities that we're really leaning into. One is focusing on the needs of those with the most significant behavioral health conditions. Second is substance use disorder as a standalone. What does that look like? Third is peers. We really believe in peers. We've done a lot to really elevate peer voices, but also expanding peer workforce to be able to support individuals who have high behavioral health needs. And then innovation is another piece of it. Counties used to have innovation locally. They would do plans, create innovation plans, and then submit them to the commission for review and approval. Counties do have a little bit of funding left for innovation, but the vast majority of it has now come to the state. And actually, most of it is not in innovation anymore, but we do have allocation right now that's up to $20 million for the next 5 years for the commission to run Innovation Partnership Fund grant program, which we are right in the middle of. And it's also part of the current budget conversations. But as part of that priority one of the things that the commission is looking to do is start looking into housing. One of the observations and something that's come up in our conversations as it relates to housing is how much confusion there is about housing. I think we've heard a little bit of it today. I know I came in just a little bit ago, but in terms of what are the housing needs of individuals with high significant behavioral health conditions, and we think people with significant behavioral health conditions, thinking people who are living with schizophrenia or bipolar disorder, schizoaffective, or moderate to severe substance use disorder, or co-occurring. And it's like and the more stratifications or the more populations we're getting into, the more complex the care is, and the more collaboration that's needed across different systems. And that's one thing that we've observed, is that there's a lot of confusion in terms of what is needed for the different stratifications of the population. And I think folks are trying to do their best with what they know, and it's a complex system, but really getting clarity on what is needed for different populations. And so thinking about older adults, just even some of the things that have been talked about today, the unique needs, you have the care needs, especially if you have folks who are experiencing dementia or Alzheimer's, and then have been living with schizophrenia and maybe even have a substance use condition. I mean, it's like there's all these layers of complexity that require very tailored supportive services. So what does that look like? What should this look like? How do we really support individuals so that they can live optimally for their lives in the communities in the least restrictive setting possible. And so that is something we're wanting to lean into or begin leaning into in the upcoming fiscal year in 26-27 to at least begin those conversations. I don't think we're going to solve it in 26-27, but want to start at least shining a light on it because I know for me, as I've been in this executive director position for about a year, but prior to that, I was the executive officer at the Council on Criminal Justice and Behavioral Health. It's just housing is just such a key component. It's foundational for everybody's life, as part of the basic needs. And again, there's a lot of good intent, but we tend to see a lot of breakdowns in terms of those system collaborations, really having an understanding of the needs of different individuals who are being served by these systems. So, and how to have people work together. I'll just say a little example of a project that I worked on, which was a housing project between the California Department of Corrections and Rehabilitation and Housing and Community Development, and two totally very separate departments. And just even I was serving as a facilitator, trying to bring a project together with them, and just even using a word as simple as services got us tripped up for about 4 months, and so, I mean, it's but it's so simple, but when we're working together, you kind of we use our words, we think we're meaning the same thing, and then we find out that we're not, and really it impacts the care that we're delivering to people in our communities. And so, so there's a lot to be learned, I think, in terms of our commission. We're wanting to help support implementation of Proposition 1 for a variety of populations. I know I meet with the Department of Aging team, and so was working even recently on talking about the master plan on aging and just thinking about what are some opportunities to get synergy, even cross-team collaboration and working to just do this basic education, because if we don't know what we're supposed to be doing, then we're going to be working in the wrong direction. So it's really getting clarity on who our populations are, what are the needs of those populations, and is that showing up in, say, our community planning process? Are we seeing, are we getting the right data? Are we getting the right information to help folks advocate? And then there's folks who can't advocate because they're in crisis. Their families are just working. I can even think I've had my own older adult that I've had to support, and my loved one who I supported through dementia, and just doing that was so challenging. And I can't even imagine doing that kind of supportive work with limited resources, even more limited than what I had at my fingertips, and then having the layers of navigating really complex systems of care, especially when you're trying to bring together partners such as county behavioral health, maybe medical managed care plans, the housing system, the social services system, and sometimes even law enforcement, depending on the population. Especially when we're talking about our high behavioral health needs population, we do tend to see a lot of justice involvement with those populations as well. So anyway, mostly just to say, I wish I had more solutions for all of you, but I think what I'm bringing is ideas for opportunities, because we are right in this big transition right now. Proposition 1, BHSA goes live for the counties July 1, and that's really going to be kind of a new day of this new way of working with this amazing funding source that other states are, wish they had access to, and we do have access to that. So even when we think we're behind, we actually are quite ahead of other states in this space. It's just learning how and figuring out, working together on how to do this optimally. So, okay.
Thank you very much. And we're thrilled that you're in this position to move this area forward, and looking very much forward into working together on that. But love to open this up for questions and comments from our fellow commissioners. Commissioner Frank, who has been serving as our liaison. We appreciate this very much.
Thank you. Hi. Thanks so much for your presentations. They were both great. And so we've been hearing throughout the day that RCFEs and other types of housing often do not want to take people with behavioral health issues. And I wondered whether or not the funding that is being made available through Prop 1 for the housing and housing supports will be able to improve that?
That's a great question. I mean, I think it's very nuanced in the sense that, yes, I think there's opportunities to be able to put that into the planning and the thinking process. I will say one of the things I've come across in terms of the reluctance is lack of training, lack of understanding, working with a high needs behavioral health population who also oftentimes or can be behavioral in addition to can have behaviors. And if there's a staff team that's just not prepared to work and know how to apply best practices, like even know what those best practices are, then, I see a reluctance. And it's not just with like an older adult population. I see this even in my previous job, folks not wanting to take a justice involved population, or substance use providers not wanting to admit folks who have a mental health condition, say schizophrenia, even if they've been, stabilized for a year or two. And so there's just a lot of stigma and misinformation and a real need for training. I think I've been involved with the Department of Healthcare Access and Information's development of their WET plan, their 5-year workforce education and training plan. And that's probably one of the things that has me the most excited right now in terms of I just can't underscore how much this workforce piece is foundational. I mean, there's like the housing is foundational, but you need the right supports to be able to have folks be successful in those housing placements. And so, yeah, being able to either lean into it in terms of, I don't know, funding to incentivize, but also training to empower. So, yeah.
Thank you. Commissioner Parker Martin.
Yeah, thank you, Brenda. That was a really great. And I have a question for both of you, but I'm going to start with Brenda.
Yeah.
Regarding the funding for workforce, you heard Harrison Linder a little bit ago talk about workforce in his presentation from Leading Age California, and they were awarded a very large grant for workforce funding through HCI and a supplemental grant from CDA. It appeared that the behavioral health funding wasn't going to be eligible for continuation, even if they focused on behavioral health services. Is that changed perhaps?
I think that would probably, I'm not as familiar, so I did hear him say that, but I'm not quite sure because I am not an expert in HCI's portfolio, but I think that would definitely be a good thing to follow up with HCI on and find out and see how that's working with this WET plan that they are also developing.
Yeah.
Because the idea is with the WET plan is training the behavioral health workforce to be able to support individuals in a variety of different settings.
Yeah, great.
Yeah, yeah.
Thanks.
Good question.
And then a totally separate question back to your presentation about the expansion and preservation funding. You mentioned, I wrote it down somewhere, but it looked like it was about $900 million that was funded originally.
800.
Was that one-time funding or is this ongoing funding?
One-time funding.
So is there a need for advocacy for continuation, or was that at just a certain point in time, like 2022, when there was a $96 billion surplus?
Well, I could never push for you advocating anything, but I would say
That's correct. Sorry.
I do want to point out that, particularly the preservation operating subsidy dollars, there are facilities that would be closed now without that money, without counties providing that money to facilities. And I think increasingly there's going to be a higher and higher number of those facilities that really would close without that money. And that money is going to run out. We have some counties that are already spending through their entire allocation for operating subsidy payments. So not encourage you to advocate, but just pointing out it is, I think if you were to talk to counties, that's a real deep need to keep these sort of smaller mom and pop facilities that are serving, 6 people, 10 people, 12 people in their community, allowing them to have supportive services in their community that might go away without ongoing funding.
Thank you. My second question also relates to that funding. And you may or may not know how to answer this, but it appeared that the number of units that were funded under that, 900 million or so of preservation and expansion were about $250,000 per door. Is that accurate? And I'm just wondering, what sort of suggestions you might have in terms of how that funding could be distributed, maybe even in an innovative way differently than it was to reduce that amount.
Yeah. For the 805 million, you're saying it was a 250,000 for the 7 or the 8,000 plus beds. I'd have to do the math on that, to be honest, because I think on the preservation side, the dollar amount is far lower for the beds
Yeah,
preserved.
that was about 20,000 based on your numbers.
Right. So you're talking about the expansion side.
I was actually looking at the total. I just said
Yeah. Yeah.
the money, this is the number of units you said. So
So I think preservation, much, much, much lower cost than you're talking about per bed to preserve people in their housing. Like, expansion, it really is expensive. I can't, there's no way I can talk my way out of that one. I think any developer would come up here and tell you the same thing, that it's enormously expensive to build housing,
yes.
especially when you're offering supportive services for folks. That really brings up the cost. What we also did with CCE is we offered a COSER, which you heard from the mutual housing presenter earlier, a capital operating subsidy reserve to some of our developers. And so what that is, that's not a traditional thing that most grant programs offer. It's like they look at their pro forma and they say, oh, wow, over our first 5 years, we're going to be this much short on our operating expenses. And so we allowed part of our grant to include a COSER so that they would be able to stay in operation over a specific amount of time. But in terms of like high cost of land, high cost of labor, high cost of the California housing market, I can't offer solutions on that front, unfortunately. I wish I could.
And
Maybe Brenda can.
anybody still, oh, excuse me. Go ahead.
Totally teasing.
If there's nobody else, can I ask one more question? Okay. I loved, and I think it was you, Brenda, who commented on whatever it takes approach, but it might have been you. I'm kind of mixing all the voices today.
Whatever it takes.
Whatever it takes, that whatever it takes approach. I love that. And I'm wondering how we could apply that even more directly in some of the things the commission is working on. I mean, it sounds so obvious, and we know it's not so easy. So do you have any thoughts or suggestions on how?
I mean, it's just it's just kind of the approach that was taken at the turn of the century in the late 90s. Like I said, that's what these pilots were, that were really looking at folks who were living on the streets, who were in and out of incarceration, the emergency room. I'm just saying there's got to be a better way to do this. And so that's where it kind of revolved into the whatever it takes. And they started taking it a full and like holistic, wraparound, comprehensive approach to serving individuals. And it's really just providing people with the care that they need and the supports that they need to live their best life in the community. And I think it sounds easy, but it is extremely hard, especially in systems where we have multiple siloed systems. And we've said this over, we use that word silo. We've been using it, I think, for over like so many years now. But it's really, that's leaning into breaking down those silos, getting past the word services. Even as you're saying supportive service, I'm like, what's he mean by supportive services? So, it's like, because it's going to mean something different.
It's a 9-page definition.
It's a 9-page definition. See, there you go. So, what does that mean? And really getting, again, that clarity, because until we have that clarity, then it's like we're just going to be talking past each other. And then, what I'd love to see is, I've seen changes over the last 20 years. I'd like to see an acceleration of getting a little bit faster to what we really need to support individuals in their communities. So it is a whatever it takes. And I guess we have to define that too.
Thanks.
We had one question as a quick follow-up to Commissioner Parker Martin's for Mr. Mills. In terms of clarification about the source of the funding, was CCE funding originally federal or state? And a little additional corollary, since you've only been able to address less than 20% possibly of the potential demand, what lessons learned could be translated, given obviously funding would be the major solution to expand your impact, but other lessons learned that could be applied across other programs or that could be new ways to expand this type of effort rather than if we do not have direct funding going forward.
Okay, so a 2-part question. It was originally community health-based funding and state general fund and federal funding. The federal funding was ultimately converted into state general fund. So it's really all state funding. CCE is all state funding, no federal funding. And the question is really, without funding, how could we continue this effort, sort of a thing? Yeah, totally. I get that. I think to me, preservation of existing housing units is really, really crucial, because I think you see a lot of these operators operating in communities. They've been operating there for decades. They know the community. They have their referral streams. They're putting people into beds when they need them. And when you lose that resource and when you lose those beds and they become market rate housing or a Walmart or whatever they become, they don't come back. And to speak to the other commissioner's question, Commissioner Martin, it's really expensive to build them from the ground up and to start all over from the beginning. So I think in terms of bang for buck, making sure that we're preserving the housing that already exists by the people that know how to operate it, and then making sure they have the money to operate long term, particularly providing the supportive services they need to keep those people housed. You can spend a lot less keeping someone from going into homelessness than you can bringing them out. And I think, to me, that's a really cost effective way to move forward.
Thank you. Commissioner Frank.
Thank you. So I just wanted to ask, the full service partnership already under the MHSA already included housing as an option in the whatever it takes mentality. And how is the new 30% that's been carved out of services now going into housing? Does it go through a full service partnership type of a thing, or how is it going to be done for the housing?
They're two separate buckets, but the idea is that we're focusing on getting folks housed. And so
Yeah.
making sure that, especially for people who are in full service partnerships who need housing, that they get what they need. But I don't think you have to be in a full service part. And I'm not an expert on this. My next thing would be also, even if you guys want to spin off into this and go a little deeper into the services, connecting with the Department of Healthcare Services, because they're the ones who are responsible for implementing all of the policy guidance for BHSA. And so all of this, they've got a policy manual online that's just chock full of great information. And but it's actually just a great resource to look into, and then kind of thinking about how putting us through the lens of older adult community. How do you bring it to life for the older adult community, those who have, again, the highest behavioral health needs. So counties, again, are the ones who are the system that's responsible. County behavioral health departments are responsible for the highest behavioral health needs. So again, thinking things like moderate to severe substance use disorders, serious mental illness. Also might be thinking about what the managed care plans, what role they can play in a lot of this. And I do know that DHCS, as part of their behavioral health transformation efforts, is looking to really have the local counties take a more comprehensive approach to planning. So not having BHSA in a vacuum, but having it be part of like the community needs assessments that the Medi-Cal managed care plans have to do, or some of the planning that the local health jurisdictions have to do. So it's more comprehensive instead of siloed even in that way. And I think there's a lot of confusion because I know it's already come across my desk since I've been in this position of, if it's in the DSM, then the county behavioral health departments are obligated to serve it. And it's like, it's just because it's in the DSM does not necessarily mean that could be outside their scope of practice. So, so it would be, really understanding and helping the communities understand like who's responsible for what, and then how do you coordinate across those systems?
Yes, because we do have many concerns about older adults with behavioral health problems. And the BHSA, because, most older adults that have behavioral health problems fall into the mild to moderate category.
Mm-hmm.
And I know those have been assigned over to the Medi-Cal managed care, but not all older adults qualify for Medi-Cal.
Mm-hmm.
And so there's just huge gaps there.
Yep.
In being able to serve people that used to be able to be served by the counties. And so I think that the challenges, since we know that older adults were the tiniest population group ever served, through the county systems, I'm really glad that they're beefing up the data collection and all of that, because we'll be able to see as BHSA is implemented whether or not there's even further reductions in serving older adults. And how much of the housing issue money can go towards older adult support, since they are the fastest growing homeless population, but they may not have, they fall into homelessness for different reasons. So, you know, we're going to need to watch that.
Yeah, it's a great point.
And I would just like to follow up with one corollary, Ms. Grealish, on that. Again, with the plans being submitted this month or finalized, what are the specific, can you speak to where you see measuring, monitoring the number or the resources going to older adults, persons with disabilities, and a follow-up opportunity in the downstream for tracking this or adjustments to plans? Do you envision that being considered for older adults?
Yeah, I think actually DHCS is already doing that. They've already got the metrics laid out. It's already a plan that they have in place. And so and we'll be able to, we do our own reporting. We have a mandate to report on full service partnerships. And so we have already, and even in the past, done an older adult stratification based on feedback that we received to do that. And we're happy to do that with the data that we receive. But yeah, DHCS has a whole quality and equity advisory group that's working on. There's already measures that have been identified, and they are full steam ahead on working to get that A, defined, and then B, implemented so they can do the tracking.
Thank you. We really appreciate hearing that and look forward to next steps. Thank you both. Any final questions? We'll thank you again for really very informative, and congratulations on all the work that you've both been doing. We look forward to the next steps.
Thank you so much.
So at this point, we get to turn to comments from the public for our remaining time. So we are unfortunately not able to take comments from folks who are online. We thank you all for joining us, but we will be asking for your questions and comments later on. But at this point, we would appreciate anybody who is present to be able to provide comments. We can take a mic around, or you can come to the front of the room. So the floor is open. We would also encourage that all comments be kept to 2 minutes so we can get around to all individuals. And unfortunately, we are taking input, not acting on any issues, and our commissioners will be listening closely, but not responding to the comments. So at this point, the floor is open. We see a colleague in the back and one in the front.
Okay. So just take it on. Okay.
And could you please tell us your name and affiliation?
Certainly. Good afternoon, commissioners. Thank you for your public service and your commitment to taking care of each one of us. Aging is a reality. Every day we grow a day older, and it's a universal need that needs to be met. My name is Sai Nagarajan. I'm from the East Bay and CEO of Chikara. We're a philanthropic Japanese-American venture focused on reimagining the future of elder care through the application of physical AI, scientific AI, and all of the emerging technologies that we believe can fundamentally improve the quality of life for elders, caregivers, and operators. I'm here to do three things. One, just to learn more about the pain points, the problems, and the possibilities that all of these stakeholders face, on the premise that we cannot afford to forget those that are in most need, right? So we've got to make innovation a real reality for them. Two, I'd like to invite folks to join our ecosystem. We're just pulling together an ecosystem of innovators, operators, investors to say, how might we better learn from each other so that we can expand the art of the possible and actually create real impact. And last but not the least, right, how do we also involve global ideas into this conversation? As a Japanese American venture, we've been exposed to some phenomenal innovation in Japan and East Asia, which we believe could benefit our constituents and our citizens here in our country. So with that, Sai at Chikara.ai would love to continue this conversation and be part of the solution. I must wrap up by suggesting I'm a former economic development commissioner for the city of Fremont, but here in my private personal capacity, in the interest of strengthening public-private partnerships and just figuring out ways in which we can have rising tides that lift all boats. Thank you.
Thank you for your interest and support. I believe we have a question over.
Do you want us to come stand? Yeah.
Hi, I'm Jean Galliano, and I'm here from the Los Angeles County Department of Aging and Disabilities, focusing on older adult and disability homelessness prevention and rehousing. I just wanted to mention a couple things. the challenge in getting RCFEs to accept clients who have experienced homelessness has been echoed multiple times today. We've always talked about it and always dreamt that there could be some kind of a, I don't know, state subsidy for RCFEs to take those customers in, even if it was a subsidy for like the first 3 months, because that's when a lot of the intensive work happens. So there's that. And we also had kind of always dreamed of the same thing for PACE providers, because PACE providers, well, like any provider, you want to cherry pick because you're overwhelmed, you have too much work to do, you want to take the easy people and fill your roles. But could that also happen for PACE providers? So we can get them to accept unhoused clients, maybe a subsidy for 3 or 6 months. And with regard to the training and the RCFEs that you'd mentioned earlier, in having success in housing people who are formerly unhoused, is we have St. Paul's PACE in San Diego, and they've done that. St. Paul's PACE has found a way to expedite the process for people who are unhoused, because that process can take a long time, and they have to be in interim housing. Unfortunately, they can't take people directly off the streets because of the state requirements, but they have found a way to expedite the process to connect people to PACE, which generally people who are that high acuity are screened out of housing because there's no one to take care of the needs. So they've combined PACE with senior housing to bring people in off the streets who normally are not able to be housed. And lastly, one thing that St. Paul's did was they came up with a whole series of training for the PACE providers to teach them how to deal with the regular issues that may come with people who have been formerly unhoused. And they've been very, very successful. So just want to share that.
Excellent material. Thank you.
Hi, I'm Minna Hilarif. I'm a reporter from the investigative reporting program at Berkeley, and we're reporting on older adults through a project called Aging in America. I'm wondering if you guys are able to answer any questions right now.
We're generally not doing it, but please, why don't you put forward your issues, and we'd love to hear, and thank you for focusing on this area.
Yeah, of course. So I wanted to ask, in-home support services is losing funding, and I spoke to two of the people on the commission beforehand, and we talked about HomeSafe and PACE also losing funding potentially. So how would you say that you guys are planning to move forward with, some of these programs that have been existing while they're losing funding?
It's a very timely and pertinent question. I'll just start. I know any one of my colleagues could certainly jump in on that because it's important for you to know and for our audience that the commission is taking a position concerning the May revise and where we are with the state budget, that the number of issues need to be strongly addressed where we are seeing a loss in funds. Our first challenge and our first goal is to retain, if not grow, the amount of funding for these programs because they are central, PACE, IHSS, et cetera. So we look to that as the very first step, and knowing how progressive California is in addressing the needs of our older adult and population of persons with disabilities, we anticipate strong response so that we do see continued work. After that, we will, of course, the commission will continue to advocate and support the aging network in this space. Thank you.
Hi, I'm Tita Bladen. I'm a commissioner for the El Dorado County Commission on Aging. El Dorado County stretches from the border of Sacramento all the way up to South Lake Tahoe. So I do have a couple of rural questions in that context, although not all of our county is rural. We at least have El Dorado Hills, which is kind of suburban. In-home supportive health, super important for us, but the people that are actually working in the services, affordability for them is a real issue. They can go and work at a fast food place and get more money. So all these cutbacks in federal funding for Medicare, Medi-Cal is really impacting their ability to keep supporting our older adults and people with disabilities. My second point is when we think of protecting existing affordable housing, in our county, we have over 70 plus mobile home parks. So mobile home parks are kind of a different animal in itself in that people may own their own mobile home, but they're actually paying space rent. And we are having the difficulty of space rents possibly escalating due to LLCs coming in and buying the parks. So we need some sort of guardrails. I know local policies have been put in place throughout the state of California, but for us, if there are some sort of common state level guardrails on mobile home park space rent, that would be of great help to us. Thank you.
Thank you for that input.
Okay. It's me again.
Please.
Because you mentioned the May Revise, I also wanted to say, along the lines of preserving being so much less expensive than building, excuse me, to keep people from falling into homelessness is way less expensive than letting them get into homelessness and then trying to deal with that situation, which is why I'd like to bring up the interstate funding formula that's proposing some major cuts to our AAAs. And those AAAs combine with all the stuff they do from nutrition to connection to benefits, et cetera. Those are all the furthest upstream prevention methods where people don't ever even need to touch the system. And to be cutting that at a time where so many other things are getting cut, it's just a concern for us.
Thank you. The commission certainly wants to address that issue.
Steve Gaskill, I spoke earlier. This might be something I just don't know. So I have to ask what type of partnerships are even possible with foundations and the types of private monies that are philanthropic. As I noticed, mutual housing, some of those gaps were filled in by non-state funds. What does that look like? And how do you manage that? That will help me understand at least that part of the equation.
Thank you. That's a very nice opportunity for because philanthropy has been major supporting older adults and persons with disabilities, but it gives us a chance to thank the California Endowment for allowing us to have this meeting today. So again, a very important area. So at this point, we again will give a final opportunity for any additional comments from the public. We absolutely want to make sure that individuals who've not been able to join us today have a chance to provide input, questions, suggestions, input. We are in the process of collecting more information and we'll now be able to share as I wrap things up for our program to share what we'll be doing next. And I'll ask again for more input and help in doing it. So in closing, first, I'd like to not only thank all of our speakers and individuals who put this meeting together, but just reinforce the fact that we already have seen today that we can't solve this issue through just state policy, through state budgets. It will take an effort from community members, local government leaders, advocates, legislative staff, and other stakeholders to ensure that older adults and persons with disabilities are integrated into all considerations surrounding housing. In the next few weeks, our next steps will be to collect more information. Again, we encourage you to send that to staff at the Commission on Aging. We'll make available how you do that. We'll be compiling findings in that area. In addition to that, we will be looking to make action items and put that together in a formal report that will be coming out later this year. So we have learned a number of things. I can just do my own quick summary to share a few points, but we need to add more. And again, our fellow commissioners will continue to pull these ideas and add them. But clearly, fundamentally, we've learned again today the importance of supportive housing, capacity, the need to increase it to ensure that older adults really we can address, begin to continue to address the homelessness situation here in California. We also know that there's a need for assisted living and other forms across the continuum of housing that will help in this regard. Also, that streaming affordable housing for older adults can increase capacity. We've learned that a number of ways we can improve efficiencies. In addition to housing as part of a larger continuum, we need to focus on that, as well as, of course, on prevention. We can take away that lesson learned that prevention can take us so much further. And finally, one other point that emerging programs such as Prop 1 need to integrate older adults to in order to really mitigate homelessness. So at this point, I'd like to thank all of our speakers who did an amazing job, wonderful information that was shared with us. The lessons learned have been very deep and resonate with all of us. In addition to our next steps, we're going to be reaching out for additional information. So in addition to thanking our speakers, I'd like to thank my fellow commissioners who have been very proactive in this area. Thank our amazing staff at the Commission on Aging. Thank you, Carol and team, who put all of this together. Thank again the endowment for offering us a location. They've been very supportive of this space over the years. And most importantly, we need to thank as represented by our speakers today, all the staff, agencies, programs that have worked hard in this field who are doing the day-to-day work. Without them, we would not be having the progress we need to have in terms of addressing the needs of older Californians. So we thank them first and foremost. Again, we appreciate you all joining us. Much to take away. We wish you a great day, and please stay with the commission as we continue to do this work. Have a good afternoon.